Hello, everyone. Welcome to our ICARE Genetics Case Conference for Thursday, October 12th. I'm Tua Pal and really excited about this case conference. I am going to go ahead and turn it over to Brenda to present our first case.
Thank you. Yeah, so this is a 28-year-old with a family history of BRCA1 mutation. So she came in saying that her maternal grandmother had a BRCA1 mutation. The grandmother had breast cancer at 50, and then there was other more distant family history of breast cancer, but not even the grandmother had a copy of the genetic test report, as it's often the case. And so it was just by report. Her mother had ovarian cancer at 45, but she had not had genetic testing. I can't quite recall if mother was not interested, but mother's still living. And so we focused our conversation on BRCA1, assuming that this was true. And so to my surprise, this patient did not have a had that CHEK2 moderate risk variant, the I157T. And so, it was great news for her, but now I had to counsel her on this new moderate risk mutation. And so, as you guys know, this is a moderate risk allele, or mutation. And so, in the past, patients were counseled to have an increased risk of breast cancer, even if in those that had this particular increased risk variant. And so in our clinic, we're using CanRisk to calculate people's breast and ovarian cancer risk in inclusion of their mutation. But for this particular one, we can include this CHEK2 variant in CanRisk because CanRisk uses the typical CHEK2 mutations and not the low risk allele. And so based on family history and other personal risk factors, her lifetime risk of breast cancer was 16.3. So it's not above that 20% threshold. And so increased breast cancer screening is not indicated for this patient. And if you go to NCCN, now there is a particular, there is a note about this particular variant saying that most missense variants are unclear, but some likely pathogenic variants, such as the I157T, the risk for breast cancer appears to be lower. And so breast cancer screening should not be based on this variant, and it should be managed based on family history. And then furthermore, the ACMG practice resource that was recently published, which, Dr. Helen Hanson is going to talk about, and then, you have Doug Stewart, Dr. Tua Pal, Mark Tishkowitz, that contributed to this paper. It goes through all, they review all the different studies that have, all the different risks associated with CHEK2, moderate risk, high risk. And so according to the ACMG practice resources, this is not an actionable mutation for breast cancer screening in isolation. And so again, consistent with NCCN managed based on family history. However, for colon cancer, there is a slight increased risk. I think it's like 1.5 to 2-fold increase, which is still below 10%, but NCCN recommends increased cancer screening for colorectal through colonoscopy starting at 40 or 10 years younger than the earliest diagnosis in the family, and repeat every 5 years, which, if I'm not mistaken, that's the same as if you had a first-degree relative with colon cancer. So essentially, having this variant does not colon cancer. And so essentially we're managing these people based on family history.
Okay, well, thank you, Brenda. I think there might be some people that are having technical difficulties joining the call. I do see that there are a number of people on the call, but our guest expert, Dr. Stewart, has been trying to join for the last 15 minutes and is getting an error message. So with that, I'm just going to go ahead and introduce both doctors Helen Hanson and Dr. Doug Stewart. So Dr. Hanson is a consultant in genetics at the Royal Devon University Healthcare NHS Foundation Trust, Exeter, UK. I think she just moved there recently from another facility, and she is a an NIHR Senior Investigator Fellow, Faculty of Health and Life Sciences, University of Exeter, UK. Dr. Stewart is a Senior Investigator in the Clinical Genetics Branch in the Division of Cancer Epidemiology and Genetics at the NCI. I've had the pleasure of working closely with both of them on a number of guidelines that we have developed and are in the process of developing, with CHEK2 being the one that we released a few months ago. It's been ready for a while, but it took a while to get out there. And this was one that Dr. Stewart and Dr. Hanson led. So with that, I'm going to pass it over to Dr. Hanson until we can work out what is going on with Dr. Stewart and his error message.
Okay. So thank you. So yes, I think I probably just have to wing it slightly until Doug joins. So Doug was going to talk everyone through the slides, and I was going to lead on the case studies. But I think, you know, the slides really are a run through of the paper, and you know, it's not very exciting, lots of the statistics we've got. So I think probably the most interesting thing is the cases. So we'll go through the slides quite quickly and then get to the cases. But maybe if Doug joins, then you can jump in and let me know. So as Troy says, I'm a cancer geneticist in the UK, and I've had the pleasure of working with this ACMG group over the past couple of years on this clinical practice resource for individuals with CHEK2 germline pathogenic variants. And so one of the studies on CHEK2 was undertaken in Denmark in the Copenhagen General Population Study, and this was a really definitive study, and they looked at their extensive cancer registries and studied a whole host of cancers that had potentially been associated with CHEK2. And you can see that there is a whole list of cancers, and I'll jump to the next slide, which shows it a little more clearly. The ones with the open circles are ones that had previously been associated with CHEK2, so breast cancer, but then all of the other cancers were cancers which maybe previously hadn't been closely associated. And what they showed was that actually CHEK2 probably is a multi-tumor predisposition gene, but for cancers other than breast cancer, the risk is probably at a very low level. There were some anomalies, so you can see the stomach cancer was shown to have an association, but actually when you drill down to the numbers, there was only a very small number of cases with stomach cancer included. And importantly to note that actually a number of these associations, when they performed some additional statistical analysis, that not all of these achieved association. But again, what they really showed was that CHEK2 was recognised as a low to moderate risk tumour predisposition gene. You know, because there has been so many studies over the years which have linked CHEK2 to different cancers, and the risks have really been differently reported by different studies, there has been such a large amount of, I think, complexity and uncertainty about what we do in clinical practice and how we manage patients who have pathogenic variants in CHEK2. And it's been sort of increasingly more important because as CHEK2 has been added to panels and we are starting to see more and more cases come through, there's been this real clinical need to know what to do in our clinical practice, as was highlighted by the first case. So this group of us have got together and really looked at the literature in detail and come up with some, you know, guidance on what to do in clinical practice. So to summarize what is in the paper, we went through and we separated out truncating and missense variants because there does seem to be different risks associated with truncating and missense for the different cancers. So we looked at things which we felt we clearly could use in clinical practice. So, where we had more confidence in saying that there was a clear association. So in terms of truncating variants, it's clear that there is an association with breast cancer, but we would look at truncating variants, again, alongside a personalised assessment, looking at other factors such as family history. And we would consider that truncating variants have a moderate association with breast cancer, so a relative risk of around between 2 and 4. Missense variants, and we are not talking here about the I157T or the S428F variants here. Most other missense variants have a low to moderate risk, so a relative risk of around 1.5 to 2, but there are some exceptions. So if you look in the paper, there R117G does seem to have a risk that's equivalent to truncating variants, and so we would likely treat that variant in the same group as truncating variants. But then the missense variants I157T and S428F actually seem to be low risk, and so they have a relative risk of about 1 to 1.5, which is the same sort of level of risk as a polymorphism. So really low. So there is an association, but very low risk. And then in terms of breast cancer, for males, we can see that there is a moderate risk, so relative risk of 2 or greater. So we looked at breast cancer and split that down into the different groups. And then for the other CHEK2 associated cancers, we felt that really, other than for colon and prostate, the studies are still quite conflicting and limited. So we pull out colon and prostate in the paper. We say for truncating variants, there is a low to moderate risk of colorectal cancer. And again, for missense variants, there is a low association with colorectal cancer. So we're managing really in the context of family history. And similar for prostate, there appears to be a moderate association for truncating variants, but the risks are much less clear for missense variants. And for all other cancers, we felt the risks were much less clear. So just sort of going through that in a little bit more detail. So in these slides are very busy, so we won't go through them in huge detail, but for truncating CHEK2 variants, there is clear evidence from the studies that are available, so the carriers and bridges studies, where there is an association with an odds ratio of greater than 2 for truncating variants, and is a little bit higher for the 1100 del C variant. But for missense variants, the risk really for these common CHEK2 variants, I157T and S428F, is really much lower, so odds ratios of 1.3 and 1.26 from those studies. Whereas rare missense variants in CHEK2 have an odds ratio about 1.5. And there was another paper published by the Dorling et al. A year later than this, which did try and separate out the missense variants in a bit more detail. And again, it's clear that there probably are some missense variants that are associated with slightly higher risk. But still most of them seem to be have an odds ratio of less than 2. Then in terms of contralateral breast cancer, again, the studies do seem to suggest that overall there is an increased risk for contralateral breast cancer. So women who have been affected with Warren's cancer do have an increased risk of a contralateral cancer. And then in terms of male breast cancer, again, the studies are suggesting that CHEK2 truncating variants are associated with an increased risk. So you can see from a Finnish study, the odds ratio is around 4, and then another study from the US, again demonstrating odds ratios of between 2 and 4. So then moving on. So then in terms of other adult cancer risk, I think one of the things we wanted to really clearly make clear from this paper is that CHEK2 is not a cause of Li-Fraumeni syndrome. And this is been an unfortunate association going back to a paper from many years ago where CHEK2 was proposed to be associated with Li-Fraumeni syndrome in a family, but actually really was associated with the breast cancer in the reported family, and so CHEK2 does not cause Li-Fraumeni syndrome, but unfortunately this still appears on many reports, and I think is something that's been very hard to get rid of. So we really call out in the paper that these things should not be in the same sentence together. And then, as I've mentioned, other than the breast, colorectal, and prostate, there is some evidence of association of CHEK2 with other cancers, but the risks are much less clear. and it's really hard to tease out because the studies are limited by either ascertainment bias or small numbers. And so we didn't feel, reviewing this within the expert group, that actually we could make recommendations for any of these cancers, because there is still some uncertainty, and obviously things will change, and there is emerging data for some of these cancers. And also, there is some reports about potentially decreased risks of lung cancer. So again, varying information. And the other thing we pulled out was that there's no increased risk of ovarian cancer. So there's no evidence of association for ovarian cancer. So we could be clear about that. And then in terms of biallelic CHEK2, it does seem, again, the studies are quite small, but it does seem that there is an increased risk of breast cancer if somebody has biallelic CHEK2 pathogenic variants. And the studies are estimating that the risk is probably double that of heterozygotes, so at least 40% lifetime risk or greater. And interestingly, there's a few papers that we pull out in the practice resource about for certain variants. There seems to be a phenotype associated with chromosome instability, but that doesn't seem to be true for all biallelic carriers. So again, probably more information is needed on biallelic carriers going forward. But the risks do suggest that maybe we should be treating these women differently than if they were heterozygous carriers. And then in terms of pediatric cancers, so there has been some studies which have shown an association of CHEK2 variants with pediatric tumor risk. But again, overall, there doesn't seem to be strong evidence that germline CHEK2 variants are associated with an increased risk of pediatric cancer. Exome sequencing studies have not shown any significant increased numbers of CHEK2 carriers within those studies. So at the moment, although there has been, some reports of an association, we wouldn't consider CHEK2 as having a significantly increased risk of any pediatric cancer. So where does that all leave us in terms of clinical actionability? Well, again, to emphasize, CHEK2 is not associated with Li-Fraumeni syndrome. We would say that CHEK2 is established as a moderate risk breast cancer predisposition allele. But even when you have a truncating variant, there is a significant impact of other factors such as family history, and therefore how you manage that patient in your clinical practice should really still consider all of those other factors and not just that CHEK2 variant. So we still should be looking at a personalised risk assessment, and using a tool such as CanRisk is incredibly helpful because you can incorporate information about their hormonal risk factors, their family history, as well as their genetic test result. But at the moment, you can only input into CanRisk CHEK2 carriers who have truncating variants. In terms of colorectal cancer and prostate cancer, then there does seem to be an association, but more of a low to moderate association. So we would advise managing that patient in the context of their family history. And then for other cancers, we felt that there was currently insufficient evidence to support any change in clinical management for cancers such as renal or thyroid or hematological tumours. So what do we do? So as I've mentioned before, we know that family history influences risk in CHEK2 heterozygotes just as it does in anyone in the population. We know that PRS scores can have an impact, although we're not widely using these in clinical practice at present. But the use of a tool such as CanRisk can really help guide our consultations with patients. So it shouldn't replace our clinical judgment, but it can really help provide some estimates. And I think some of the cases have got some CanRisk examples in. Again, we discuss polygenic risk scores in the paper, and at the moment, we know that they have an impact in the setting of breast cancer, but in terms of other cancers, then there's very little information. So we don't know how that risk might be modified by PRS scores for other cancers such as colorectal or prostate. And you can't use CanRisk or a similar tool such as CanRisk for those variants. So just to re-emphasize that CanRisk is really helpful for individuals who have truncating variants, and should be used to help guide recommendations for surveillance and also risk-reducing surgery. But at the moment for colorectal and prostate cancer, because we have no similar tool such as CanRisk, then we would really just look at the family history as the main guide to how we should manage these families. If we have individuals who have missense variants, then we can't use CanRisk, but we know that the risks are likely to be much lower than for truncating variants. And so we would advise in these situations that we just manage the patient on the family history and not that genetic test result. And the I157T and the S428 F variant are associated with lower risk, so really a sort of relative risk of 1 to 1.5. So in isolation would be difficult to change management. So that's a run through of some of the data, and hopefully that will help us answer some of the the cases going forward.
Thank you for attending. Many thanks to Helen and Doug. Doug, so sorry for all of those technical difficulties, and we will see you next time.